Okay, so good morning, colleagues. Good morning, everyone. Thank you for joining us on this Friday morning for this PANCAP Knowledge Share Fair. It's not our first share fair, but it's our first one that we're hosting virtual. And so please bear with us if we have some minor technology hiccups as we go along. We've tried to, and I say this because we've tried to make the share fair as interactive and as participatory as possible. And so we anticipate, but we hope that we wouldn't, that there might be some technology challenges, but this is our first one. And we certainly hope that it will get better as we go along. So again, welcome. I think one of the lessons that we have learned a few years ago when we started doing knowledge management formally within the partnership is that stakeholders, NAP managers, civil society organization, persons from the key populations community wanted to hear about local or indigenous experiences that were happening in the region so that the lessons that are learned can be more applicable within different countries and within different contexts. More recently, we celebrated Dominica's achievement in terms of EMTCT. And one of the feedback that we received at PANCAP is that it would be really good to hear from countries that have been validated as well as countries that have been revalidated, and that this will particularly be useful for countries that are preparing for validation. And I think that this was also noted because Dominica, for example, was validated recently, but that validation process somewhat took place during the time of COVID. And we know that COVID, we're not over the pandemic. We still have a long way to go, and there are countries that are preparing for their validation. So to really be able to talk about what have been the experiences of countries in achieving validation, particularly focusing on some of those challenges and how they've overcome the challenges, and what are the key lessons that countries have been learning.
Morning. Please
So
tell
this
Shania she needs to review
today,
the vaccine database and do some corrections.
Penny,
She
can
seems to
I
have
ask
started to
you?
confuse the occupation and address columns. So I have persons whose address is police officer and occupation is sailor.
Penny, can I ask you to
The
mute
flash
your
drive is in my
microphone?
desk. You got it yesterday? Okay, I will need the corrected database.
Okay, perfect. So sorry, I apologize for that, and maybe I should have started out with some housekeeping notes to say that I'm asking that you please keep your mics muted. Penny has just unmuted herself again. That you please keep your mics muted when presenters are presenting. I think there is a raise hand feature so that you can raise your hand or you can unmute your mic, and that will be an indication to us that you'd like to speak. And so please keep your mics muted. So moving on to the objectives for today's share fair. Timothy, if you can help me with the next slide. Moving on with the objectives of today's share fair. They're pretty straightforward. One, we would like participants to leave the share fair with an improved understanding of EMTCT Plus in the Caribbean. We would like to share examples of successful experiences of EMTCT in the Caribbean, including the challenges that we've faced, how these have been addressed, and what are some of the key factors that are critical for success for EMTCT validation. And in all of our share fairs, we want to be able to foster collaboration between National AIDS Program managers, civil society representatives, all of our technical partners, and all of the stakeholders within the partnership. At this point, okay, great, thank you. So this is today's agenda, a quick welcome, a hashtag competition. Thank you for all of those that have submitted your hashtags. We will have an expectation board, a panel discussion, a close-up by Dr. Mutu, a second hashtag competition, a review of the expectation board that we would have conducted at the beginning, an event survey, and a quick closing. So thank you, Timothy, for sharing the housekeeping. Notes, please keep your mics muted. Click the hand icon during discussion if you'd like to make a point or a comment, or you can also type your questions and comments in the chat bar that you have. And those are some resources that are available to you. So moving on, I will now introduce Dr. Rosman Adams, who is the director of the Pan-Caribbean Partnership Against HIV and AIDS, to bring us his official opening and welcome remarks. Dr. Adams.
Thank you very much, Shanti, and good morning to everyone. It's really a pleasure to see so many of you on very early on a Friday morning as we wind down the week. I know that for us in PANCAP, we have had a very long week, especially coming out of the UN high-level meeting on HIV. So it's good that so many of you are on to participate in this our first virtual share fair that we're having. As Dr. Singh would have mentioned, this is not our first share fair, sorry. We would have had face-to-face events, but due to the ongoing COVID-19 pandemic, we had to relook the way in which we do things. And we've recognized that the sharing of information at this time is more critical than ever. And so we need to continue to engage all of our stakeholders, be it national programs, civil society organizations, donor funders, etc., so that we can continue the momentum and that we can continue to motivate stakeholders to ensure that HIV still remain on the agenda, and that as we confront the ongoing pandemic, that HIV is still a topic or a disease area that still require our attention. We know that as we respond to the COVID-19 pandemic, that HIV still remains a public health threat in many countries, and therefore the work of PANCAP and the partnership is to ensure that we do all that we can in our remit to really strengthen and scale up the response to HIV. So this share fair is coming at a very interesting time. We've just concluded last week the National AIDS Program Managers meeting, in which we discussed scaling up the national and the regional responses and strategies to do that. We had also just concluded the UN high-level meeting and the resulting political declaration 2021 to 2026 that will guide the global HIV response. And as part of that, in the political declaration, there is a strong focus on ending inequalities where women, children, girls are disproportionately affected by HIV. And so I think that this share fair, focusing on the elimination of mother-to-child transmission, comes at a very critical time where we try to see how we can ensure that no one is left behind, and we really focus on reducing new infections among our women and girls. I think that as Shanti would have mentioned, Dominica was the last country in our region to be validated for the elimination of mother-to-child transmission. And it came at a very difficult time when we were confronting the pandemic. And so they must be commended for this. But even as we speak, there are a number of countries that are in the process of being validated and are being assessed. And so we hope that with the sharing of information from the share fair, that it is really meant to share information, to collect perspective, and to enable those in other countries to understand what are the challenges, what are the bottlenecks, etc., so that they can really overcome these barriers, and we do not have to reinvent the wheel, and that they can move forward as a region together. So I won't say too much because I know that we're pressed for time. So again, thanks to everyone. Thanks for Dr. Singh, Timothy, the coordinators, and the presenters who will be presenting today. And I I hope that we have a very successful session, and that also it doesn't end here, but we continue to really strengthen the elimination of mother-to-child transmission in the Caribbean, and having more countries being validated and revalidated as we move forward. So thank you very much, Shanti. Back over to you.
Yeah, thank you so much, Dr. Adams. At this point, I'll ask Cedrian Martin, who many of you would know is the communication advisor for UNAIDS regional support team, but also Cedrian Martin is the chair of the Knowledge Management Working Group for PANCAP. So over to you, Cedrian.
Good morning, everyone. Happy Friday. Thank you, Dr. Singh. I'd like to start by thanking PANCAP, Dr. Adams, Dr. Singh, Timothy, for the excellent support to the region in getting us through the high-level meeting and truly informing in very concrete ways a solid CARICOM position that led it to a strong political declaration. As Dr. Adams noted, there is a commitment in the 2021 political declaration to ending inequalities, and there's also a concrete commitment to eliminating mother-to-child transmission of HIV by 2025. As we know very well, the Caribbean is ahead of the pack in terms of this particular agenda, and what we just need is a little fine-tuning. How do we get it right in terms of our data, in terms of our evidence, particularly around syphilis, because it is a dual elimination target? How do we get things right in terms of leaving no one behind, whether it's on the grounds of migration status, poverty, self-stigma, actual stigma and discrimination? So I really do look forward to today's session. As usual, these knowledge management sessions really have real life applicability. They could make a difference. We know that we've kept all the balls in the air throughout this COVID-19 experience, and PANCAP especially coming out of HLM and being able to keep the ball in the air in terms of planning this particular virtual share fair. So congrats to the team, and I'll look forward to today's session, look forward to the insights that we will get from participants and to applying them regionally. Have a good session, everyone.
Yeah, all right. Thank you so very much, Cedrian. And I know both Dr. Adams and Cedrian have spoken about the high-level meeting. So I know a lot of persons have been in attendance, but also, if you have not been, PANCAP has been putting out a lot of press releases and communication on the meeting. So stay tuned, look at some of what you've been receiving from Timothy, and there's a lot of resources out there on the high-level meeting. I think at this point, what do we have on the agenda? So we have our first hashtag competition, and I will launch the poll. If we can quickly vote. So we've sent out the hashtag competition as a pre-event activity. Can you see the poll?
Yes, we can see.
Yes, you can. Okay, thank you so much, Dr. Adams. We've sent this out as a pre-event activity, and I think so you only have one. You can only vote once, and so I am going to hand you over to Timothy so he can quickly explain to us what will happen with the hashtags and how we will use the hashtag going forward. Go ahead, Timothy.
Thanks so much, Dr. Singh. So there are about 5 or 6 hashtags that you will see in the poll. When you can just vote on one. That hashtag will be used on all the communications that will be sent out to update the entire partnership on some of the outcomes, some of the comments, some of what you have to say here at the Share Fair. We're going to use it on all our social media platforms, Instagram, Facebook, and Twitter. So be very precise and careful when you pick. We want the best hashtag to win. These were submitted by all of our participants. They're quite good, but I'm asking you just to select the best one, the one that is concise and really speaks to the Share Fair. why we're here and what we're doing and what we hope to achieve. So please be very precise and take your time and choose one that you think is best so that we can look good on social media. Over to you, Dr. Singh.
Awesome. So Timothy, I wonder if you can talk a little bit about tweeting as well, and maybe taking photographs as the Share Fair is happening. Some of the more communication, social media things that we talked about.
Sure, Dr. Singh. So as most of our participants would know, the Share Fair is a more informal than the NAC managers meeting. You can let your hair down, undo your tie, wherever you are, if you're at home or if you are in the office, just relax a little more. It's not as formal as the NAC managers meeting. So, and today's Friday, as Dr. Adams mentioned. So if you can just take a selfie of you in front of your computer, wherever you are. Normally at this time, if we're meeting face to face, we would do a nice group shot or get some shots from our participants. I would encourage them to post images of themselves at the meeting and just use the hashtag that we're going to select right now. So if you can just take a selfie in front of your computer, in front of your laptop, whatever you're doing, and post it on your social media, use the hashtag that we're going to select. And we will, of course, share those images with the entire partnership. So if you can take us, even if it's a screenshot or a shot of your screen that you can share on your social media, whether it's Facebook, Instagram, or Twitter, please go ahead and do so, so we can share. We just want to ensure that we share some of your thoughts and highlight your participation in today's Share Fair. Back to you, Dr. Singh.
Yeah, thank you, Timothy. And I think we have a winner. The winner is hashtag PANCAP Share Fair Learning Together. So thanks a lot to the person who would have submitted that. I think that all of the hashtags were really good. I don't know, Timothy, do you have who submitted this, this hashtag? Hashtag PANCAP Share Fair Learning Together.
I think it may have come from the participant from Haiti. Let me just double check that. I can get it for you before we end.
Okay, all right, great. Okay, thanks everyone for participating in the poll. I hope that you can actually use the hashtag. I'll ask Timothy if he can help me by typing the hashtag and putting that in the chat. You can use the hashtag if you tweet during the Share Fair or anything after the Share Fair that's related to the Share Fair. So I will go ahead and end this poll. At this time, I will, in terms of the expectations, so one of the things that we do at our Share Fair is that we try to establish what participants' expectations are, and we review those expectations at the end of the Share Fair to determine whether or not we've met your expectations. And if we haven't, if there is a consensus on a particular expectation, then we see how we can follow up to meet those expectations. At this time, I will, there is a link that I've put in the chat. If you can click on the link and type your expectation, I have up on that link, it's actually a Padlet. And so you can go onto the Padlet and you can type your expectations and you will see, I'm gonna actually share the screen. So as you're putting in your expectation, I can see what those are. You don't necessarily have to type your expectation below the first expectation, but on the Padlet, right down on the right lower end of the Padlet, there's a pink circle with a star. You can actually click on that and add your own expectation. It's anonymous, so we don't know, we don't necessarily have to know who is submitting what expectation, but any expectations that you may have of their Share Fair over the next already hour and a half. But we do have a few. One is to understand more about what the plans and ideas for HIV/STI in the region are. I'm not sure we will delve a lot into that, but we're taking note of some of those expectations. Examples on improving data collection with limited electronic resources, and I'm hoping that some of our presenters who will be presenting on the panel will also take note of what some of these expectations are, so that if it's possible as you present, you'll be able to touch on some of these to share information and collaborate. And I think that's what we're trying to do with the Share Fair, to gain information on any community-led responses in EMTCT in the Caribbean. For example, such as Mothers to Mothers model in South Africa. And so for the panelists, if there's any community-led EMTCT responses in your countries, you may, I think we'll appreciate if you can touch on that. How to improve testing of babies at 18 months. And again, the panel discussion, we hope that some of these will come out. Again, I don't know, Timothy, are you seeing the pink circle with the plus on your Padlet?
Yes, I can see it. I can see it in the browser. So I think most persons.
Right. So maybe just someone can just add a new expectation by clicking on that. Maybe you can try that, Timothy, so that we can see. Yeah, so you can click at the lower end on the right side. There is a pink circle with the plus. You can actually add your own expectations separately. But I think this is good. How to serve hard to reach women living with HIV and their families. Interesting. I know that Guyana is on the panel and Guyana is presenting. And Guyana we do have some hard to reach communities just based on geographic locations, for example. So I'm hoping that maybe Guyana would be able to touch a little bit on what are some of the strategies they have been using to reach some of the hard to reach communities and women living with HIV, and in the context of EMTCT as well. I think this is good. Thank you all for your expectations. And I will close off on the expectation board at this time. So we will review again the expectation board at the end of close to the end of the Share Fair. And as I said, the outstanding expectations, we will see how we can address those, not necessarily today, but at another event, whether it's a webinar, whether it's another Share Fair, whether it's another knowledge sharing event by the partnership. And so at this time, we are into our panel discussion, and I will hand you over to Dr. Rosamond Adams, our director, director of the PCU, who will moderate the panel discussion. Over to you, Dr. Adams.
Thank you very much, Shanti, again. So the panel discussion is actually the meat of today's session, if I may put it that way, because this is where we're going to share information, and this is where we will open up to have a plenary in terms of the information that is being shared by the panelists this morning. In terms of a background for before the panel discussion, we know that in 2019, an estimated 7,800 women in the Caribbean needed ARVs to prevent mother-to-child transmission of HIV. Of those, 6,700 received ARVs, which accounted for 86% coverage. With these and other EMTCT initiatives, 1,300 perinatal infections were averted in the region. The mother-to-child transmission rate in the region is at the end of 2019 is reported at 12.1%. The Caribbean, as was mentioned earlier, has led in the elimination of mother-to-child transmission of HIV. And in 2015, Cuba became the first country in the world to receive validation from the World Health Organization that it has eliminated mother-to-child transmission of HIV and syphilis. In 2017, an additional 6 countries were validated: Anguilla, Antigua and Barbuda, Bermuda, Cayman Islands, Montserrat, St. Kitts and Nevis, as achieving dual elimination. Most recently, on May 14, 2021, the Commonwealth of Dominica was validated as achieving dual elimination of HIV and syphilis. And so the objective of today's panel discussion are to understand the challenges in preparing for validation of EMTCT. We know that it is not an easy task. It can be a long process. So we will understand and we will hear some of the challenges from countries that have been validated, to share experiences and lessons learned in achieving EMTCT, and to understand the importance of integrating EMTCT Plus in maternal and child health programs for successful validation and for successful elimination of mother-to-child transmission. We have with us this morning 4 panelists who will be speaking to us, and they will present about 5 to 7 minutes on the EMTCT initiatives, challenges in their countries, and then we will open up after for plenary discussion where you can pose questions either verbally or via the chat to the entire panel or to a particular panel member. Our 4 panelists are Mrs. Jennifer Joseph, who is the PMTCT coordinator of the Commonwealth of Dominica and led the in-country validation process. She is currently pursuing studies in management of HIV infections at the University of the West Indies. Ms. Joseph will present on Dominica's experience with validation, including the challenges and some of the nuances related to the pandemic in terms of, going through the validation process while confronting the COVID-19 pandemic. And Dominica, as we said, being the last country in the Caribbean to have achieved validation, I am sure that Mrs. Joseph's intervention is quite updated, and she can speak to you not only on the challenges of EMTCT, but also the challenges of maneuvering with COVID-19. So I'll hand over to Mrs. Joseph.
Good morning, everybody. Thanks for the opportunity to share. The Ministry of Health of the Commonwealth of Dominica throughout the years has recognized the importance of prevention and elimination of disease and has stayed the course in ensuring that healthcare providers keep up with current trends to prevent and manage the occurrence of diseases. The elimination of critical transmission of HIV and syphilis, EMTCT, gave Dominica, my country, the opportunity to prove that it can verify and document its role in the eradication of this disease as major public health threat. Moreover, from my standpoint as coordinator of the PMTCT of HIV and syphilis, the process was explorative and evidence-based. The national healthcare providers' commitment and dedication in achieving the certification of multi-child transmission of HIV and syphilis was remarkable. However, the attainment of certification did not come without its fair share of challenges and identification of gaps. As a member of the Validation Committee, a steering team headed by the Chief Medical Officer of the Ministry of Health afforded me the privilege to participate in all aspects of this elimination process, specifically collection and verification of data from various data sources, for example, antenatal records, public laboratory, and maternal registers in the community. This rigorous process of data collection and analysis was necessary to indicate that Dominica has achieved the targets as outlined in the EMTCT strategy, such as HIV multi-child MTCT rate, antenatal coverage, percentage of HIV and syphilis testing, incidence of perinatal HIV, and congenital syphilis for the period 2015-2019. The team painstakingly scrutinized the data and pinpoint gaps in the different programs and surveillance system. The MCS program needed to be reviewed to establish the guidelines for the timely, consistent management of infants born to syphilitic mothers for the prevention of congenital syphilis. Also, during the desk review and assessment of pregnant women records, the turnaround time for syphilis screening results for antenatal, specifically for the bookers, presented as a challenge. We recognized that there was a minimal lack of consistency in documentation, but felt a sense of pride in the proper storage of records to enhance safety and security during natural disaster hurricane occurrences such as Tropical Storm Hurricane 2014 and Hurricane Maria in 2017. As part of our plan of action for the implementation of this collection, private physicians who routinely manage pregnant women and regularly screen for HIV and syphilis will offer the survey which utilized standardized questionnaires. We noted with gratification that information obtained from the questionnaire that if there was a positive result, the appropriate management would be implemented for all exposed infants of HIV and syphilis. All exposed infants of HIV and syphilis captured during the collection of this activity would be audited and entered on audit sheets with inclusion of modest particulars such as gestational age, priority, prior results, type and date of treatment given. In the comment column of the sheet, detailed information will be written in reference to management. This was a tedious, intricate, and repetitious activity on condition of possible non-correlation of information, nonetheless relevant and precise. In the course of the validation advancements, we appreciated PAHO's timely and inspiring presence as an EMTCT mission was made to strengthen and finalize the report, to conduct a training session with relevant staff, MCH, surveillance, and HIV, to develop an appropriate roadmap to address the gaps that were identified, and to strengthen EMTCT services in Dominica. The PAHO team undertook site visits to major community clinics to understand the manner in which EMTCT services were organized and made appropriate recommendations. Evaluations were also done at private sector labs to appraise standards as part of the process. Consequently, internal validation was carried out. Stakeholders met, including the MCH committee, to discuss and obtain approval on the information in the report. The PAHO Group timely second mission visit was held. The draft validation report was submitted to PAHO for review and later to the Regional Validation Committee, RVC. The RVC advanced the report so that an EMTCT virtual assessment would be conducted with the lead of Global Validation Committee, GVAC, and chaired locally by the CMO. Dominica's road to success for validation of EMTCT sometimes went past normal working hours. We labored on weekends and holidays, occasionally during sick days, yet we persevered. Our achievement and validation would not have been possible without the meticulous, relentless, and valiant effort of Ms. Sandra Jones, technical advisor, HIV, STI, and viral hepatitis, and Ms. Annick Wilson, country program specialist, diligent and profound work. For the endurance, we say a heartfelt thank you. My participation in this process, the persistence and commitment displayed in the journey to certification of elimination of mother-child transmission of HIV and syphilis was extensive, but worth it all. Thank you.
Thank you very much, Mrs. Joseph, for that detailed overview of the process that Dominica went through in order to achieve validation of mother-to-child transmission of HIV and syphilis. You have not only highlighted what had to be done, but you highlighted the challenges and what you had to do to overcome these challenges in order to ensure that the data was collected, the data was validated, in order to get feedback from pregnant women, and even the challenges with confronting natural disasters such as Hurricane Erika and Maria that would have put some delay in the quest for evaluation. Notwithstanding this, you persevered and you now have a certificate of validation from the World Health Organization, and I'm sure that the next step will be that when it's time to be revalidated, that you're revalidated. But very important for us at PANCAP and for the region and for Dominica is really not the certificate. It is ensuring that the lives of the women and children are impacted, and that that no child is born with HIV or syphilis, and that we reduce new infections, we reduce HIV and syphilis in our countries. So I thank you very much for this, and I'm sure that there are going to be questions for you as we go on in at the end of the of today's panel discussion. So thank you very much for sharing Dominica's experience. Our next presenter is Dr. Karina Palmer Ford, who is the head of the Women's Clinic in the Women's Health Department at the Health Services Authority. Dr. Palmer Ford graduated from Messiah College with a Bachelor of Science degree in biology in 2000 and with her medical degree from St. George's University School of Medicine in 2005. Uh, it is also a joint presentation where Laura Elniski, who is a nurse who have received her Bachelor of Nursing with honors from Glasgow University and a Master's in International Public Health, specializing in sexual health from Australia. Laura um, is the STI and HIV Program Coordinator for the Cayman Islands. Dr. Palmer Ford and nurse Laura Elniski and nurse Beverly Samuels worked on the initiative to validate the elimination of mother-to-child transmission of HIV and syphilis in the Cayman Islands. Dr. Palmerford and nurse Elniski will present on their experience in achieving validation and revalidation. Thank you very much for being part of the panel. Welcome, and it's over to you, Dr. Palmer and nurse Elniski.
Thank you. Sadly, Dr. Palmer is unable to make it, so it'll just be myself presenting. I don't know if I can share my screen, or I did send Shanti, but it was probably too late. The presentation, I don't know.
Yes, you can go. Yes, you can go ahead and share your screen.
Laura.
Oh, sorry. Where's?
At the bottom, there's a green button that says share screen. If you click on that, then it will bring up the screens.
Yeah, I can't see it. Where did it go?
Dr. Singh, I think you have to enable it from your end, please.
Can you see it now?
It is enabled, Timothy.
Can you see it now?
Not as yet.
We're not seeing it. Did you say that you?
Now?
Okay. Yes. Yeah. Yes, we're seeing it now. Yes. Go ahead.
Okay.
If you can put it in full screen. Yes, great.
Yeah.
Go ahead.
Hi, I am Laura Elniski. I'm going to present on where we are in Cayman. All our pregnant females are tested twice for HIV and syphilis during pregnancy, or that is our protocol. We have public sector and private sector. Both in our public sector, we have one hospital that does deliveries, and then we have another hospital that is a private hospital that does deliveries. However, both private obstetricians can deliver at either place, the public hospital or the private hospital. And I'll talk about that challenge a little bit. We did submit a report in 2016 and got our confirmation for validation in 2017. That data was the 2012, 2013, and 2014. We submitted and were revalidated in 2019 using 2017 and 2018 data. In Cayman, we have had no mother-to-child transmission of HIV since 2004, and no known mother-to-child transmission of syphilis, none documented. We have had 4 infants born HIV positive prior to 2004. One was born in 1990, one was born in 1994, and one was born in 2000. And then, as I stated, the last one was born in 2004. We have had one positive pregnancy, one HIV positive pregnancy in 2014. The baby is negative, was born in 2015, and another pregnancy in 2016, and the baby was born in 2017, and the baby was negative as well. We do option B plus here in Cayman. We treat all, does not matter, of CD4 count. We have tried to move on to including hepatitis B, but we are waiting for the indicators to be confirmed so that we can include them maybe in our next report. However, we are looking to submit in the next few weeks. Sandra just sent back some recommendations of our report using 2019 data and 2020 data. So hopefully we'll be submitting for a reevaluation again this year. We have done our indicators all over 95% as requested. We had a great year in 2018, was 100% for both HIV testing and syphilis testing. We roughly have between 600 and 700 births a year. However, you'll see that in 2020, we had a spike. We believe that's because of COVID, that people who would normally go overseas to deliver were unable to do so. So they had to deliver in Cayman. We have seen, we believe in Cayman that we do a lot of testing, and I think we have found this throughout the Caribbean, that we are probably not any different here, that it's just hard to pull that data. So we know that pregnant women are getting tested, their partner may be getting tested as well, but to actually pull the data to show it was our struggle when we first were looking into getting validated. The gaps that we found when we were going through the process of our reporting was, again, high level testing. However, the data collection were the issues. As I stated, that we have the 2 hospitals that deliver right now, public and private, and that private physicians can deliver in both places. This becomes an issue because if you are in the public sector and you deliver in the public hospital, it was quite easy to pull that information because you did your lab tests at the public hospital and then you were delivering at the public hospital and we could pull that information. However, if you saw a private doctor, you probably did your labs at a private lab or with their hospital, their laboratory in their clinic. And then we were finding that even though they are negative, we have no way of pulling that information from their system. So we had limited data from the private sector. So when the patient came in to deliver at the hospital, we would have to look back in their file, either this being from the doctor themselves, the patient themselves, and it could be a manual process of pulling that information. The syphilis data, we did find that this was hard to collect as well at the beginning. As I said, we test twice during pregnancy, especially in the private sector, but sometimes patients have said they've already been treated, but their titers were still high. So we would want to treat again. Was that a reinfection or an old infection that wasn't treated? Where did we stand with the syphilis data? HIV was a little bit easier to collect that information on. As I have said, we test twice during pregnancy. However, we did have some kickback from some private physicians who said that you should only be testing once during pregnancy. So when we started the initiative, that was a hurdle to have that conversation. Some of our physicians are, kind of stuck in their ways and they believe what they do is correct. However, we had to have many meetings and discuss that with them as well. Another issue that we did find was at our lab health services authority is our public health lab is not named as the public health reference lab. It's not official. However, we are used as a reference lab, a confirmation testing facility, but it is not named as the public health lab. So changes that we keep dealing with and that were recommended, I believe this was from our 2014 and our 2017 that we have been working on to ensure that we can get revalidated, was that we want to make sure that everything is clear from beginning to end so that it doesn't depend on myself or Nurse Beverly Samuels, who is one of the lead midwives collecting the data. If we were to step out of the picture, that the system would still go ahead and the data would be still collected. And to be honest, at the beginning, that was very hard. Everyone is very busy and they weren't seeing this as much of a priority because we weren't having it, quote unquote, as an issue. But we did want to show that we had eliminated mother-to-child transmission. So to try and get everyone on board, we had many meetings, many presentations, speaking with the private sector as well, all our midwives. Because if a patient comes into the clinic with a negative result or comes into delivery with a negative result, sometimes the midwives and the doctors are extremely busy and they're unable to put that into documentation. And we were trying to get at a point that we need this in documentation. We can't always be going, pat back, and we should be always be moving forward. So we developed an STI registry as well. As I said, the HIV data was easier to pull. The STI data was harder, the syphilis data was harder, and going forward, hepatitis B as well. So we did develop an STI registry, and we ensured that there was data collection mechanisms at labor and delivery. So again, patient coming in, it's HIV negative, syphilis negative, but we needed the data collection to be confirmed, especially when they're coming from the private sector. We updated the postpartum and neonatal referral form. This did not include, prior to the validation, did not include HIV and syphilis results or dates. So we included that and updated it and sent it out to all delivering facilities. We did have some issues with the data collection at the beginning, but now it's becoming just part of the system. And we did, as I said, have many meetings with different sectors. We did develop elimination of mother-to-child transmission committee, and they included the medical officer of health, epi manager, public and private obstetricians and gynecologists, public and private laboratories, myself, the HIV program coordinator, public and private pediatricians. This carried on till 2017. And then now that it has become part of the system, it's already in place, that has been absorbed by the perinatal committee. They meet once a month and do all the stats for the perinatal. And then they have a management team as well. So now I am a part of that, and it has just become part of the system, as I said. And that's all I've got. So thank you very much.
Thank you very much, Laura, again for a detailed and comprehensive overview of the process in the Cayman Islands. Also listing some of your challenges, but also some of the innovations and strategies that you would have used in order to ensure that you collected the data and that you are able to achieve validation and revalidation. We noticed the challenges with the public-private collaboration, and I think in many countries that challenge still and do exist. And I'm sure that questions would maybe put to you in terms of how did you overcome these barriers. And I also noted that there were some challenges with syphilis, even even seen in the last data set that you presented, an increased number of stillbirths. But we also noted that also at that time there was also an increase in live births. So
I probably should clarify. Sandra has put this up to us that we put in the stillbirths. Those stillbirths are not related to syphilis. Okay, so in the report, they're not related to syphilis. It's just to give you an overview of how many deliveries we have and how many stillbirths. So we have never had a stillbirth reported that has been related to syphilis. Yeah. Great. Sorry, I should clarify.
Yes. I think that, yes, that clarification is very important because, as we know, one of the complications from syphilis is stillbirths, and so we will want our stillbirths to be investigated to ensure that it is due to syphilis or is not due to syphilis. So thanks for that clarification. So thank you very much, and we'll move on to our next presenter, who is Dr. Onika Scott. She's a physician of 12 years and began working in the field of HIV in 2010, managing clients in care and treatment at family health centers. She transitioned to the Ministry of Health in 2016 and continued working specifically with HIV positive adolescent and adolescent health as the adolescent health coordinator. She is currently the Maternal and Child Health Coordinator with oversight for PMTCT, and for the last 3 years, she has dedicated significant effort in working to prepare Guyana for validation for the elimination of mother-to-child transmission of HIV. Dr. Scott, welcome, and over to you.
Your mic is on mute, Dr. Scott. You need to unmute. Thank you.
Thank you, Dr. Singh. Thanks, Doc, for the introduction. Good morning, everyone. I shall share my screen now. Are we able to see?
Yes.
Yes, we are. Go ahead.
All right. So, like the rest of my colleagues, Guyana has been preparing for the elimination of mother-to-child transmission of HIV and syphilis. And we've just embarked on hepatitis B for quite some time now. In 2015, the country agreed on the elimination initiative. Right soon after that, in 2016, we started with nationwide review of the PMTCT process. And this was indeed a big venture, since if you know anything about Guyana, we're geographically large. We can fit all of the countries in the Caribbean in our country, but there's no straight path to all of the regions. And so the different regions would have their own challenges, especially as Dr. Singh had mentioned, some of the hinterland communities. But in 2016, we were able to produce our first in-house report, and we started to implement some of the changes that that report had identified. And I want to say something about the elimination process, which is gratifying to us, although there is a lot of hard work. The validation is not what we are going for only, but it's the opportunity that we've been given to correct and to improve the service so that we're able to reduce vastly the mortalities relating to mother-to-child transmission. And it's that improvement of the system that the country has embraced. And although there have been real bottlenecks, we have looked at it as an encouragement that if we're able to attain the validation, we would simultaneously be able to improve that service at all levels. In 2017 and 2018, the data-wide collection continued nationally. It was indeed a lot of work, and it still is. We do have challenges with electronic access and challenges even with paper access in some of the hinterland territories. Again, we were able to submit our report in 2018 and 2019, addressing more and more data gaps that were identified. And in 2020, we were able to update that report. So just to share a few of our indicators with you, we're proud to say that although in 2019 we did have a glitch with the mother-to-child transmission rate, we've reduced that somewhat in 2020. Our antenatal coverage has increased for those women who are accessing services and has been steady. They are receiving the test. Syphilis, however, is a challenge. In terms of treatment, we have been able to update some of our protocols, since publicly and privately, there was a great difference in how the physicians were managing those patients that were diagnosed with syphilis. There's a challenge too with the process of accepting the test to be used. In our country, we do use both the treponemial and non-treponemial test, and so we have to standardize that based on what the country has accessed. And again, the challenges in 2019 is that our rate for MTCT rose just a little bit, but in 2020 we saw a sharp decline. We have to acknowledge the very avid support that was lent to us by Sandra. She's been a real champion for the cause, with several visits guiding the process through. Guyana was able to learn from some of the other countries that ventured out to attain elimination. We thought that the work was overwhelming, but then we understood that other countries did the same thing. Unique to Guyana, and I want to reiterate here, is the inaccessible terrain based on the geography. There's some parts of the year that you cannot access parts of the country. Either there's a very low riverbed that prohibits access by boat, and sometimes boat is the only way out to the facility where the woman can get her test or where she can receive her results. And if that doesn't happen, then the process is stalled. You're not able to monitor that mother, no healthcare worker can go to the home, etc. Then there is the fact that some of these hinterland communities, the health facility is located miles away, walking. So a mother in her first trimester may walk for 2 days before she's able to go to the clinic. And you can imagine that she will not be able to visit every single period that's required for the 4 weeks at the beginning of the first and second trimester, and then later on quite regularly. So monitoring of that mother will be challenging, especially if there's something like late trimester transmission of HIV. And those are problems that have been identified throughout the data collection for the years that we've chosen. And we've seen that in some of the areas, sadly, there is not much that the system can do to curb some of those. The cultural challenges here have been identified separately, and some of them are cultural and economic based because some of our remote and rural communities do have many strong reservations on accessing care. Most of our women in the hinterland communities prefer traditional birth attendants as to the facility. And then the economic factors in those areas driving non-access to care would be mining or farming. And if the mining operations require them to move further inland or further up mountain where there's no access, then that is what they would do. So women come out almost giving birth, not having that period of a proper antenatal care. Usually we add the social biases with the cultural and economic factors, but for Guyana, we have decided that the social biases are a real challenge and are to be addressed separate by themselves, since they are still families and cultural orientation that negate the woman having an HIV test and negate also her partner being tested. This we found to be challenging, especially when a mother turns up and is tested at labor and delivery and sees that diagnosis as being something of supernatural origin. And it is indeed a challenge. But on the pros side, we do have free universal health care, and there is great bipartisan political buy-in. So right from the very political sphere at the top, the country has high on its political agenda that we will look at all of the bottlenecks. We will be mending all of the gaps that the system can fix so that we will get to that goal of elimination. We've had great support from PAHO, WHO, and the regional validation body. Again, Sandra Jones has not left our side. She has been quite supportive. And because of that support we've had, we're making inroads. And we hope that come 2022, we will be able to join the rest of our Caribbean countries in attaining elimination. And that's where we'll end for today.
Thank you very much, Dr. Scott, for that update in terms of where you are in Guyana and the numerous challenges. We know that Guyana, compared to a number of the countries in the region, is very huge, and even though it is huge, as you move from one area to the other, there are a number of unique challenges, and so I think that the availability of healthcare providers to be able to reach, especially far reach areas, as you would have stated in your presentation, is certainly one of the challenges. But we recognize these challenges, and we recognize where you are on the way to validation. We've heard in the last three presentations, and the PAHO sub-regional advisor on HIV, STI, and viral hepatitis, the role that Sandra has played in the region and continue to play in working with countries to be validated in terms of the elimination of mother-to-child transmission of HIV, syphilis, and even adding on viral hepatitis. And I'm sure Sandra is online and will come into our discussions later on. Our fourth and final presenter in terms of the panel is Dr. Natalia Lagespada there, who is a technical advisor for maternal and child health advisor, and she's also a member of the Regional Validation Committee. Dr. Natalia will talk about the importance of an integrated MCH EMTCT Plus approach. She will also share key observations from the Regional Validation Committee that will be useful for countries to note as they prepare for validation and revalidation. And I think that this presentation is very important because here Dr. Natalia will share some of the challenges as part of the Regional Validation Committee, some that are common, some of the challenges that they see across the region, and what can be done to overcome these challenges. But she can also share with us, I'm sure, best practices as we go from one country to the next, and what are some of the innovations or strategies that can be used to support MCH and EMTCT in the Caribbean. Dr. Bear, over to you.
Good morning, Dr. Rossman, Dr. Singh, colleagues, panelists, and dear listeners to these presentations. Good morning, all. Warm greetings from Belize. If you allow me, I will share my screen. And just a reminder that PMTCT, the mother-to-child transmission of HIV, was first recorded in 1988, that is 33 years ago, and this occurred in Thailand. And as I was looking at the history of this case, we can see that it causes hysteria among healthcare personnel, so much that the woman was not allowed to deliver in the delivery room. She had to deliver at the AIDS ward. And we are still facing these kind of stigma and discrimination, even from healthcare workers. So it's not an easy result to achieve, which is the elimination status of mother-to-child transmission of HIV, syphilis, and hepatitis B. The HIV epidemic among pregnant women began in 1990. Cuba was the first country in the world to be certified as eliminating mother-to-child transmission of HIV and syphilis. And this is a great achievement for the region of the Americas, for the Latin American and Caribbean sub-region, and for the Caribbean sub-region, as they are part of the Caribbean countries. The Caribbean, with no doubt, is an example to the world. We have documented so far 14 countries worldwide who have achieved the elimination status. And out of these, 53.3% are countries within the Caribbean sub-region. And I want to echo here just like the previous panelists, the role that the Pan American Health Organization has played in securing, working together with the countries for this achievement. And in particular, I would like to join the panelists in giving a big thank you to Ms. Sandra Jones. She was the star for us when we started PMTCT in Belize, and she continues to support Belize in this road towards achieving elimination. It's difficult to achieve the results that we are pursuing if we just wait on pregnant women to start the prevention of the mother-to-child transmission of HIV and syphilis. We definitely need to start from before. And this is a reminder of the four-prong for the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. For HIV, preventing HIV infection among women in reproductive age. For those women who are living with HIV, prevent unintended pregnancies. And for those who got pregnant and are living with HIV, well then the task is to prevent the transmission from the mother to the child. And the services do not end with the childbirth, but rather we must ensure the continuum of care, not only for the newborn, but also for the mother and for the members of the family. So treatment, care, and support is key after the birth of this child, which we are making all efforts to ensure that the child is born free of HIV. So learning and implementing together, there is no other better example than PMTCT. In Belize, we started in the year 2000. We started through PAHO Technical Cooperation among countries. We learned in 2000 from the Bahamas, and we used that experience to start our program here in Belize. We started out with 2 of 6 districts, and 1 year later, we had it integrated into the maternal and child health package of services. Like any other country, we have been updating our standards and protocol based on evidence. We too also, around the year 2015, 2016, we had sharing of experience with Suriname. So we also had an opportunity for technical cooperation among countries with Suriname. EMTCT, HIV, syphilis, and hepatitis B is also integrated into the services in public and private sector, including non-governmental organizations that come in contact with pregnant women. What we have found, we are not certified as yet as eliminating mother-to-child transmission of HIV. We did our first report, we prepared our first report around the year 2016. And well, we did our own assessment and we knew we were not meeting the target, so we could not submit our country report. And since then, it has been a struggle for us to meet the indicators. But what we have noted is that there is a high burden of the social determinants of health. Women sometimes have limitations making the best decisions for themselves or for their children. We see a lot of issues related to gender-based violence. Some of our women that are living with HIV live in difficult circumstances, for example, in poverty. A few of them have poor schooling. So it's a challenge because all of these issues are outside of the control of the health system. We do believe that the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B should be a public good. Doesn't matter where the woman accesses the services. She needs to, we need to provide her with screening, with treatment, with follow-up services, without the family having to pay anything for these services. So in the lease, no out-of-pocket payment is required for screening, treatment, and follow-up services that we provide. It's everyone's business. I totally believe in this because whilst they have the heaviest component when interacting with pregnant women, and these preventive interventions to reduce the risk for transmission from mother to child, it takes the entire system at all levels to play an active role. Everyone should be accountable for the prevention of mother-to-child transmission of HIV, syphilis, and hepatitis B. We work closely with the private and the public sector. We have our network of community health workers at the community. Community members and community leaders play a key role, especially for the interventions. If we remind ourselves of the 4 prongs, the first prong, which is avoiding getting infected, or women in reproductive age acquiring HIV. So this concert of all of these players is necessary for us to achieve the results that we are pursuing. So it's not easy because at each contact, there is a need to document these services. And sometimes we fail to document accurately the services that we are providing. I think Cayman Island raised the same issue with the difficulties collecting data on syphilis, and that is one of our area of weakness also. I would like to just remind the persons that are participating in this session today that there is a guideline for the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. The guideline clearly states out what needs to be part of the country report. There is 3 levels of validation. We have a country level validation committee whose responsibility is to collect the data, analyze the data, prepare the report. And then we have the regional validation committee who receives the country report, goes through the country report, and if there is any need for validation, then a team is assembled to visit the country and to go through the data at local level with the local partners. And this serves to verify and to provide feedback based on the report that was received. Once the regional validation committee gives clearance to this report, then this report is raised to the global validation committee, who have the final decision for certifying a country the elimination status of mother-to-child transmission of HIV, syphilis, and hepatitis B, and the recommendation of the regional validation committee. The World Health Organization and the Pan American Health Organization are the ones who are providing the secretariat support for the EMTCT in the region of the Americas and globally. And they are providing technical assistance to each one of the countries. So in our case, just like the rest of the Caribbean countries, we have the privilege of counting with Ms. Jones to help us to achieve the elimination status. We currently working on our report for this year, and hopefully we can be certified as eliminating mother-to-child transmission of HIV, syphilis, and hepatitis B pretty soon. Our population is small, and any one case throws off the target that we need to meet. So it's a challenge. For us, it's really an issue of elimination for us to be certified. I think one of the questions in the chat was that how to improve the testing in children at 18 months of age. And we had the same challenge. What we have in place right now is we have a master list, which is managed at country level. And although in each one of the districts, we have a team that is following up on the cases, we also have one officer that part of her responsibility is not fully dedicated to, but she supports going through that list and ensuring that children that are falling behind with the testing, the districts are reminded constantly until they complete the testing for the kids. So that has helped to have someone that is monitoring case by case the services that are pending. We also have the Belize Health Information System, is an electronic medical record system. We already have a built worksheet that would help us to expedite this monitoring rather than depending just on these manual monitoring for EMTCT cases. So we hope that that system will help us to improve much more these numbers. We are having challenges just like the other countries, and even before COVID-19, I think one of the main challenges is accessing the ARVs in the pediatric presentation. It just gets worse with COVID-19. It's a struggle to secure these presentations. With COVID-19, the fear of the COVID-19 itself is limiting the contacts that we need with these women that are living with HIV. And stigma and discrimination is still an issue for our country, and I guess for many other countries. So the EMTCT Plus and being certified as eliminating the mother-to-child transmission is not an easy task. And we must be prepared to go the extra mile. And going the extra mile means whatever is needed to facilitate this result, we must, because it's the right of the child to born free of HIV. And the evidence is showing that if we achieve the viral suppression during pregnancy, then the transmission is nil. So just to use an example, Belize, we don't have the HIV DNA PCR testing in country, so we procure every year these testing from a private laboratory abroad. And some of our patients required assistance with transportation, for example, to collect meds and medication and to do their follow-up laboratory testing. And the staff is committed to provide this service. So again, EMTCT Plus in the Caribbean, great achievement. And the togetherness, just like with COVID, we are together in this. With EMTCT, we are together in this also. Thank you very much.
Thank you very much, Natalia, for giving us an overview of the situation in Belize. and the role of the national and regional validation committees and how this is linked to the global validation committee and the entire process of going through validation and the need for looking at issues such as the social determinants of health. We recognize that elimination is not only the availability of ARVs, it's not only testing, but it's also looking at the unique challenges that women face in terms of access to care, retaining them on care, and ensuring that the other social determinants of health that makes them very vulnerable, such as education, income levels, issues such as gender-based violence are all addressed in a holistic manner. And we do not just look at when women come to the clinic and prescribe ARVs and test them, but we have to ensure that all of these underlying conditions that are associated with the widening inequality gaps that we've been seeing in the region of the Americas and in countries are addressed so that we're able to address these social determinants of health. You also mentioned that the EMTCT is a public good, but I'll even go further and say that it is also part of human rights. It's the right of the woman to have access to care, and it is also the right of the child that is not born yet to be brought into this world without HIV, syphilis, and other diseases. And so, as public health practitioners, we have to continue to work to ensure that that we can accelerate action in the region to ensure that the entire region of the Caribbean or the Americas as a whole is able to eliminate mother-to-child transmission. I am very much optimistic that we can do it because the Caribbean has over the years led in a number of validation and elimination in public health initiatives. And I'm certain that with this, we have shown that that so far we have had a number of countries being validated and revalidated. And so those countries that have still not been validated, we can work together and use forums like this to show them exactly where the challenges are, where they need to scale up, and what resources may be needed, so that we're able to assist them and move towards validation and getting the Caribbean being free of mother-to-child transmission of HIV, syphilis, and viral hepatitis. So thank you very much for that presentation. And so we have heard from the 4 panelists this morning, and there is going to, I'm sure that there are questions for the panelists, but before I open up for questions from the panelists, all of you did mention a name, Miss Jones or Sandra. We know that Sandra Jones has been central to the elimination work in the region, HIV, STI, EMTCT, etc., viral hepatitis. And so, Sandra, I'm going to put you on the spot. I don't know if you want to come in and give a few words in terms of the work that you have been doing in the region and any motivation for countries who are present here and are looking towards validation. Sandra, if you're there, over to you.
Thanks very much. Thank you, Rasman. Yes, thanks for putting me on the spot. I just came out of a very drooling meeting, but yes, I want to thank PANCAP for putting this forum together because, you know, sometimes the countries think that they are the only one that have the experience in trying to pull the information together to demonstrate that they have achieved the regional and the global targets for EMTCT. And so it's good for this knowledge and this information to be shared, and for those who are planning to attain. I must say that, yes, it has been some very hard work for the countries that are validated. And it continues to be a process because validation is not just a one-time thing. You have to maintain the validation. I'm thinking Valerie's on the call, and we just got off the call with the Global Validation Committee, where these are some of the issues that have been discussed. But what I would really like to actually say is that for the Caribbean to be leading globally, on this initiative, I think two things we need to take away is that it was the real vision of the chief medical officers from the ministries of health to say, you know what, this is what we're going to do for the region. As what Natalia said, this is a public health good and it's a human right, not only for the infant, but for the child. And so this decision was not taken lightly. So we have to also applaud ourselves that the whole EMTCT was born in the Caribbean. And so for us to be leading it, I think it is just rightfully so, because we could not push for something and at the end of the day, we're not able to achieve the targets. But I think more importantly, EMTCT is just the icing on the cake. It shows the hard work of the public health nurses, and I don't think we should underscore the hard work and dedication of public health nurses in the at the community clinics, and as well as it is advancing the region, is a step forward to eliminating HIV, STIs, and hepatitis as major public health threats. So I could say a lot, but I will just end here, and I will just say congratulations to the countries and for continuing the work to actually maintain the EMTCT validation status in the region. And we look forward to validating more countries, some of the bigger countries. We're looking forward for Guyana to be one of the big countries to actually advance. So thank you. And thanks everyone for your continued commitment and support and for working with PAHO, and PAHO will continue to work with you in this endeavor. Thanks.
Thank you very much, Sandra. Sorry that I put you on the spot, but we could not have had today's session speaking about EMTCT without really hearing from you. As I said, all of the panelists did mention you in their presentation, and we acknowledge the hard work that you have been doing in the region with respect to EMTCT. And as I would have mentioned earlier, the broader picture of HIV, STI, and hepatitis. The other person that I had also to put on the spot, and you did allude to her, is Valerie, because the role of the lab did come up in all of the presentations in terms of the availability of testing, viral load testing, dry blood spots, etc. And if you don't have the lab and availability to lab services and quality and timely lab services, of course, the elimination process will be difficult, because you need this data in order to support the process. Valerie, if you are with us, I will ask you to come in for a few minutes and from your experience, if you can mention to us some of the laboratory challenges and what we have been doing in the region to overcome these challenges and to support the elimination process. And sorry that I have put you on the spot.
Thank you very much, Rosman, for the spotlight, but and for putting me on the spot. But I think the region, as Sandra said, really is building a strong capacity in doing these elimination efforts. And some of the challenges for the labs have, of course, been access to viral load testing. This is the 90 measure. And it is also the measure that has to be used, as we look at pregnant women, the diagnostics in the first instance in terms of having rapid testing available at ANC sites. And I think this is something that has been done really pretty well throughout the region. The expansion of testing to those antenatal sites, definitely including syphilis, because we've been used to doing HIV. Including syphilis has been, one of the challenges to make sure that we can actually do syphilis testing for those pregnant women at those sites. And two of the things that have come up recently, and I think are really important for us to look at, early infant diagnosis, making sure that we have access to early infant diagnosis. It's a PCR test as well, but it's a DNA, PCR, and so it's a little different from the HIV viral load, but the capacity has been built in a lot of the countries because they now have gene expert technology, and that allows you to do the early infant diagnosis as well. So
I think the fact that we've actually been able to increase the access, even within small countries in the OECS, through provision of gene expert technology. And, you know, we don't give ourselves enough credit, I think, internationally. Most countries in the world that have introduced gene experts have introduced it, you know, for TB, and they've kept it very much focused on TB testing. But we always think about, well, what else should we use it for? And so it has always been introduced with what they call, you know, sort of a multiplex kind of approach, rather than, you know, introducing these things just for doing one particular disease. And I think that's a real advantage for us within the region. And the second big issue is external quality assessment. I really want to stress this, having just come off the GVAC meeting. External quality assessment and participating in that, you know, that system where external panels are sent into the country to check how the testing is actually done is really critical. So the main lab in country must do that. But what they also have to do is to do the EQA for the testing sites. That is going to become a real requirement over time. And we have to begin to be very, you know, meticulous about the way that we look at this. We did a lot of training earlier about how to do it, but I think we really need to make sure it is actually happening in a real way, because the GVAC is going to begin to require that external quality assessment, even for maintenance. So, you know, it's one of the criteria now for the labs for validation, but it is also a criterion that's going to be required for the validation, for the maintenance of EMTCT. So I just wanted to stress those 2 points. Thanks, Rosman, for putting me on the spot.
Great, thank you very much, Valerie. And you see why it's important that I call on both of you and Sandra, because you play a very important role in the initiative in the region, and we know, and we thank you for your support that you have given us in the region as we work towards the elimination in the region. We are running a bit behind time. I know that you have questions, some questions to ask, and we ask that you hold these questions for a bit. And we'll move on to the next agenda item, and we'll open up after for any question. But we have another presentation close up. We have the tools, let's use them, by Dr. Moto, who is a pediatrician here in Guyana. Dr. Moto, over to you.
Thank you, Rosamond. Can you hear me?
Yes, we're hearing you. Please go ahead.
Okay,
We're seeing you. Yes.
Thank you. In 2001, a young woman brought her 8-month-old baby boy to my clinic. He weighed 4.8 kilos, was very irritable, and didn't want to take his feeds. The little boy was severely malnourished. He had his arms flexed, his hands fisted, his skin was dry and flaking in some areas, and in his mouth there were creamy white lesions on his tongue and his inner cheeks. I took a brief history from the mother and found out that the baby's father had died when the baby was just 1 month old. She didn't know the cause of death, but he had lost a lot of weight and had diarrhea, and he also had those same white things in the mouth as the baby has. It was 2001, and the PMTCT program in Guyana was just being piloted in 4 sites. So this mother's ANC clinic was not one of those pilot sites, so she had never been tested for HIV. It wasn't easy explaining to that mother why we needed to do an HIV test on her. And it was even harder breaking the news to her that she was positive and that more than likely her baby was also positive. And then, of course, we had to tell her that we didn't have any medications for HIV yet. We enrolled that baby into our clinic. We gave him Septrin, we gave him Nystatin for his oral candidiasis. And that began my journey with pediatric HIV. In those early days, between 2001 and 2003, we had few tools in our toolkit. We had rapid tests and we had Septrin. We saw many babies during those years, some whom we could diagnose because they were over 18 months old, and some who we just presumed were HIV infected. We had no medications for them. In 2003, St. Joseph Mercy Hospital, which is the Catholic hospital where I work, they received some funding to start a program offering free testing and care to HIV-infected adults and their families. In that year, the Guyana Pharmaceutical Company started manufacturing lamivudine, stavudine, and nevirapine tablets. So in 2003, we were able to not only test people, but also to treat adolescents and adults. But we still didn't have liquid medications for the children. So we cut and we crushed the adults' tablets, and we made solutions for the children, and we gave them. I'm always very proud to say that those children who got those crushed tablets are alive and doing well today. Between 2004 and 2006, our toolbox grew. PMTCT was rolled out nationally in 2004, CD4 testing and ARVs for children were available. AZT was added to single-dose nevirapine for the exposed infants in 2006. But despite all that we had and all that we were doing, we still lost a number of infants and young children to OIs and complications of the virus. Children were still presenting late to care, and we could only diagnose the infants at 18 months, and that proved a problem for us. In 2007, we were able to do DNA PCR testing for the first time, and we used it for our early infant diagnosis. This was a huge step forward for us. We were now able to diagnose exposed infants before they were 2 months old. And if they were positive, we were able to start them on treatment before they were 2 months old. An essential part of our toolkit that I'd like to mention was the training of nurses and social workers and counselors who made a huge difference to our clinics. They helped us keep our children in clinic, and they helped keep the children adherent to medications. In 2011, we had two important milestones. Viral load testing became available, and one of our vertically infected young ladies gave birth to a healthy HIV uninfected baby boy. He was our first grand patient. Looking back, we have made big strides in Guyana in prevention of transmission, in early diagnosis, and in treatment for infants and children. It felt good to meet with a young expectant mother 2 weeks ago and to tell her about our PMTCT program and to assure her that her baby will be HIV uninfected once she remains undetectable and on the treatment that we prescribed for her. I am looking forward to also rolling out PrEP in Guyana and making it available to everyone so that we can also prevent new infections in adults and in adolescents. I'm looking forward to the day when I will not see an HIV infected child. Thank you.
Thank you very much, Dr. Moto, for that. Very touching indeed. And I think we will have you to record it for us so that we can put it on the PANCAP's website. It really gives us a look into your journey, starting with little or no resources, and as the toolbox was filled along the way, now we have the EMTCT initiative. Probably is your toolbox that is used to ensure the lives of the mothers and of the infants. So thank you very much for that. Colleagues, at this stage, I will open up for a few minutes for some questions or comments. You can direct them to any of the panelists who presented this morning.
Just to add, Rosman, that colleagues, you can just unmute your microphone and we will identify you and you can speak.
Good day.
Go ahead, Monique.
Hi. Good day, all. This is Monique from Suriname. This is actually a question to all panelists. First, I would like to thank them for their PowerPoints, the presentations, sharing their experiences with us. My question was actually if each of them could speak to maybe patient-related factors, because some systemic issues are, in my point of view, easier to fix. But then sometimes you have the patient-related factors where you lose the patient. There's non-adherence. There is, I would not say a difficult patients, but non-adherence, patients getting lost. And in the end, you have maybe a failed PMTCT result with a positive baby. So I would like to have the experience of the panel on those issues and what they are doing about those kinds of things. Thank you.
Thank you very much, Monique. Patient-related issues and what is being done in countries to overcome these barriers or these issues. I will pose a question to all of the panelists and ask that, if possible, that you could respond in a minute or so, because I'm sure that there might be the same issues as you go from one country to the next. So, Ms. Joseph, can I ask you to respond first?
Thank you. In Dominica, what is done for non-adherence of ARVs, the patients are followed very closely. They are seen by the counselor for counselor adherence, and also at the IDC clinic, which is the infectious disease clinic, where they are seen, the clinical nurse ensures that the patient adheres. She looks at, because the prescription for the ARVs are written on the patient's book. So you look at the book to see when has the patient picked up, and you also consult with the pharmacy. And when this is done, you are able to follow up to find out why the patient hadn't come, or how many times the patient was missed, and you actually consult the patient. Yes.
Great, thank you for that. The Cayman Islands, Nurse Laura, do you want to come in here?
Ours is quite similar, that if a patient is seen to be uncompliant, for pregnant women, we're testing regularly, and if they're not compliant as well, we're testing regularly. So we would do their bloods every 3 months, or initiate after initiation of ARVs 6 weeks. And then we work closely with the pharmacy if they are collecting from the pharmacist. There is only one pharmacy on the island that dispenses ARVs. We have another hospital that is dispensing some, but that's mainly to their inpatient clients. However, even though if the patients collect from the main pharmacy, we work closely with the pharmacy to see their compliance pickups. But majority of patients actually collect from myself. So I will monitor their compliance. And one of the reasons they don't want to go to the pharmacy is small island. They believe or perceive that people will know that they're HIV positive, so they want to, even though their name will be known in the pharmacy, they don't want their face to be known. So most of the pickups are done through myself. I would probably say 75% of medication pickups are done by myself, and the remaining quarter go to the pharmacy themselves.
Great, thank you very much for that, Dr. Scott.
Well, I want to start by saying that issues with adherence and compliance, they're inevitable. They will occur. What we have done is plan for them. Resources have to be mobilized in such a quantum way that we take a multi-sectorial approach. Sometimes medications are collected religiously per cycle, but they're not used. And it's even more worrisome when it's the children that's not receiving the medications for whatever reason. So you have to have that multi-dynamic team there, including your social worker. Maybe other ministries we have involved, like social services, to really sit down with that client and dissect the reason. And if you do not have the resources to case track, to work extra hours on that client, then sometimes you miss things that the system could solve. So not being frustrated by it, but planning for it, it takes time, it takes resources, and it takes an understanding that this is not unique to HIV care. It will happen. You will have people of different educational backgrounds and different social statuses that propose that challenge, but the system should have that very strong dynamic approach in place to deal with it.
Great. Thank you very much, Dr. Scott. And you did mention looking at the social issues and bringing in the social worker. Dr. Natalia, when she presented earlier, spoke about the social determinants of health. And I think when we look at adherence, retention to care, and so forth, when you really examine what are the reasons why the women are not adherent and are not taking their medication, etc., the root cause most times are due to social, a number of social issues. Dr. Natalia, what's your take on this?
Yes, Mr. Chair. I think the root cause for us is the stigma and discrimination. And this is stigma and discrimination from the family, stigma and discrimination at community level, even from healthcare workers and from others who interact with them. We find women moving around, living in one district and delivering in another district. And so we had 1 or 2 cases where they deliver with a traditional birth attendant. So I think what is key is communication between all the level of services. What we do know is when a public health nurse is following up a patient and she does a home visit and they report that the patient no longer lives there, she lives now in another district, then she would notify the next public health nurse, look for her, she needs this A or B service, and you need to look for her and provide her with treatment. But we find that the non-adherence is more common among women who live in difficult circumstances. And again, drug users, living in an environment of violence, economic hardship. And one thing we must not forget, we are working towards achieving targets, but we had one case of a patient that she was just tired of taking treatment. And she voiced it honestly like that. I'm tired of taking treatment. So option B plus, we know it's good and everything, but it's not an easy road for these women. So the more we prevent HIV among women is best than waiting till they get pregnant and trying to ensure we provide them with all the services they do to avoid the transmission. So let's not forget that component of the EMTCT Plus, the person that has to be taking treatment. Thank you.
Thank you very much, Dr. Natalia. And I think that this is linked to what I had mentioned earlier, that as we speak about EMTCT and EMTCT Plus, it's more than just getting a certificate of validation or revalidation. It is really putting the woman at the center of this and having a people-centered approach, because we have to understand the challenges that the woman themselves are faced with. And as you said in your presentation, that she was just tired of taking medication, and so we have to understand them and we have to work with them and show them, the benefits of being retained on care and safeguarding the transmission of HIV, syphilis, and hepatitis to the unborn child. So thank you guys very much for this. Are there any other questions?
Rasma, Rasma, not a question, but I wanted to quickly go back to the expectation board. I think there's some that we can address and then close off. So one participant.
Yes, Sijan has her hands up, yes.
Oh.
I just wanted to ask, Sandra, can you give us like a 1, 2, 3 of the list of things that Caribbean countries seeking validation need to address, like top priorities? And then a follow-up question to all the panelists, they hinted at it, but a little bit more about what is the approach to ensure that you get services to people who are a little more difficult? Like, is it community nursing? What's the philosophy and the approach that underpins that strategy to get to the people who may not show up to clinic on time?
Thank you, Sergeant. Sandra?
The 1, 2, 3, timely testing of all pregnant women for HIV and syphilis, the exposed infant at birth and the intervention. And for syphilis, the mother has to be treated very early as soon as she is detected. And so that links to the second point, which is lab. And I think Valerie mentioned that. The lab has to play a very critical role. The test needs to be done in a timely manner, fed back to the health centers, and the test needs to be reliable. And the third one is going to be surveillance. You need to have adequate surveillance in place to monitor and track those cases. And I think it was Dr. Bear who actually spoke to that. And so I know the latter is very challenging, but we are advocating, and I know countries are continuing to push to actually strengthen the surveillance system, because revalidation, you cannot always be doing retrospective data collection. You need to have real-time data, especially if you're going to be successful in monitoring and evaluating those cases. I can't recall, oh, and I must say, linked to the first one is the early infant diagnosis. That, and I know lots of countries could attest to this, some of them on the call, the late infant diagnosis. Because early infant diagnosis, as we talk about, it's the right of the child. And so you cannot test a child a year later to find out that this child is HIV positive or just never did get a test. So early infant diagnosis is critical. I'm sorry, what was the second part of the question?
It was about whether there's a philosophy around that outreach to patients who don't necessarily show up on time. Is it a community nursing approach? What are the approaches that work for that? And,
well,
and that could go ahead.
Right, I think the approach, most countries have a PMTCT coordinator, and the PMTCT coordinator started only for HIV, but it has now for most countries integrated syphilis, especially where the cases of syphilis, those are small. So basically the PMCT, and this goes back to they have a system to actually monitor all the cases, because then the PMTCT coordinator will be able to track those persons who have defaulted or who have not taken the child for the follow-up treatment. I know when countries are preparing their report, most of the time some of them would say, oh, the mother did not come back. We tell the mother to come back. She did not come. For validation, that does not fly with both the regional validation committee and the global validation committee. Because if a woman is positive for HIV or syphilis, and those are notifiable diseases, then the health system needs to go out and find those persons. And so those are normally tracked, and each countries have a different system, but I think for most part, they are tracked through the PMTCT coordinator. This the smaller countries. I think for much bigger countries, they have a different system that they actually utilize. And that is very important, because if Natalia spoke about having one case and how that one case can affect the rate. And so what the RVC and the GVAC looks at is that you have a one case. Show me that this case was not the fault of the health system. Because if it's not the fault of the health system, then that case would not count against you. For instance, if a mother did not attend antenatal care, showed up in active labor, when they tested her at labor and delivery, she was positive for syphilis, then that case would not be counted against the health system. But if a woman was tested at 20 weeks, and it wasn't until she got to labor and delivery that they realized, oh, this woman was positive and she had a 1 in 32, and we have seen that before, an RPR, and she was not treated, then that is a problem. And then even worse, the baby at delivery was not tested and treated appropriately. So the overall philosophy that the health system has to be very proactive in following up the cases as they exist, both mother and infant. Sorry for that long explanation.
Thank you, Sandra. No, I think the explanation was very detailed, because I think it brings perspective into some of the challenges that countries are faced with, and it is not saying that she has stopped coming to clinic, but we have to be proactive and track down all of these cases and ensure that the follow-up is done. So thank you very much for that. At this time, I will ask the panelists if they can just turn on their videos for a very short while, so that Timothy can take a print screen of the panelists for his report, and then I'll hand over to Shanti for the hashtag number 2 competition, and back to the expectation board and the survey.
Rosman, can I also ask Sandra, Valerie, and Dr. Mutu to switch on their cameras as well?
Yes, yes. Timothy, let us know when you're through.
Okay, thank you very much. Thanks. Got it, Rosman. Thank you.
Okay, great. Thank you very much. Shanti, over to you. And thanks to the panelists for your presentations today. I think we can go on and on and on, but it was really, good presentations and a good discussion so far. Shanti, over back to you.
Yeah. All right. Thank you so much, Rosman. I too want to join you in saying thanks to all of the panelists for sharing. Thank you, Dr. Mutu, for a very intimate close-up. I think, as Dr. Rosman says, we can actually put this on PANCAP's website and find a way of sharing your journey. Just so that you're aware, we have started posting on social media using the winning hashtag. And the winning hashtag is, let me see if I can get back to that. The winning hashtag is hashtag PANCAP Share Fair, Learning Together. And the winning hashtag was submitted by Penny Maloney from Montserrat. Penny, can you switch on your camera and just give us a wave so we can see who Penny is? I saw Penny. Okay, all right. Penny is in the audience, but I don't know what's happening. But I want to very quickly, mindful that we're 3 minutes over time, go into our second hashtag. And this is the one in relation to EMTCT. So we couldn't shortlist the 5 because they were all very good. So we've included more than 5 hashtags. So please, you can commence voting. Penny does not have a camera, but appreciates the recognition. But thank you, Penny, for submitting the winning hashtag. So if you can take a minute and vote on the next hashtag, I'll appreciate that. All right, it seems like test, treat, protect, no positive babies is on top. It's winning so far. There's a challenge from zero HIV babies. All right, so I think I'm going to end the poll at this point in time. The two, so we have a tie for the winning spot. Test, treat, protect, no positive babies and zero HIV babies. I'll leave it now to Timothy to continue with the posting. At this point, I wanted to share with you just so that you can get a glimpse that we've started posting on social media using the first hashtag. And to encourage you, if you'll post on social media, that you use the hashtag so that we can all connect with all of the postings on the Share Fair. Again, mindful of the time, the next agenda item is a really quick review of the expectation board. And let me just share with you the expectation board. Okay. Sorry, 1 second. Okay. Yeah. So very quickly, I think we have met most of the expectations. I think that some of them, I made a comment on this one here that Dr. Natalia has responded to this specific question, I'm sorry. I think that Dr. Mutu has, Dr. Scott had touched on the hard to reach communities. I'm not sure. 1 second for me. Just 1 second. Timothy, can you take the expectation board here for me at this time?
Hi, Timothy. Okay, so I'll continue. In terms of the expectation board, I think that one of the expectations was that resources, training to build capacity among the health sector and EMTCT and online resources. And I think that this currently exists, that there are resources that are available to build the capacity of the health sector and to strengthen health systems around EMTCT, maternal and child health, and PANCAP definitely can share this information online via collaboration with Sandra and PAHO. And I'm sure that on the PAHO's website, there is a wealth of information, including the guidelines and so forth for EMTCT. Shanti, back over to you. I'll handle the first one.
Okay, great. Thanks, Timothy. Thanks, Rasman. For the second one, I hope that we tried as best as we could to make this interactive and participatory. And I hope that we would have achieved this. I think there has been really good sharing of information. Our panelists have done a fantastic job, and thanks for the inputs from Sandra and Valerie, and to Dr. Mutu. I think when we talk about EMTCT, we've heard a lot about the technical components of EMTCT, sort of like how to treat a pregnant woman, how to test and treat an exposed and HIV-infected child. But I think we've gotten a lot of information in terms of the experiences at country, both at the level of the systems as well as the individual level. I think that Dr. Scott did touch on some of the challenges and how they've addressed those in Guyana in terms of how to reach, how to serve hard to reach communities. I think that was good. Dr. Natalia responded to the 18 months testing. We did talked about data collection, surveillance, and so I think we've touched on that ask. In terms of more ideas on HIV and STI in the region, similar comment to what Dr. Adams made in terms of resources and training. But I also know that Sandra has been working with colleagues at PAHO to set up an STI online training program. And I think Sandra, maybe you can send a, when the link is ready, we can share that with all of our stakeholders. This is one of the online courses that PAHO has on its training platform. And so that will be available to stakeholders, of course, in addition to all of the other sharing that's happening at PANCAP and by your partners. To gain information on community-led responses in EMTCT in the Caribbean, I don't think much was said on this during the panel discussion and our conversations today. And maybe I can ask, I think Sandra, you have a good view of what's happening in the region. I don't know if there's any examples that you can in a minute touch on very quickly in terms of this objective and this expectation, and then I'll continue. Sandra, do you have an example on this specific one that you could share with us?
What is it, please? Sorry.
It is about whether there is any community-led response in EMTCT in the Caribbean. So for example, in South Africa, there's Mothers to Mothers. Is there any community-led response in the region?
I don't know of any, but as a part of the regional validation committee, we do have women living with HIV on the committee and participate in the mission. No, but I don't know of such response.
Okay, all right, great. Thank you, Sandra. Thanks everyone for putting up their expectations. And I hope that while we may not have comprehensively addressed each one of them, I think we've had some really good sharing from our panelists. And I will quickly move into the post-event survey. If you can, please, we're asking that you complete this survey within the next minute or two. So it's just 3 questions. And it's anonymous. All right, thank you so very much. I'm going to go ahead and end the poll. We will look at the information. If there are any next steps that we will have to do based on the feedback, we'll be in communication with you. And again, very mindful of the time. We're 15 minutes past end time. I will hand it over back to Dr. Adams to do a closing of the Share Fair. Thank you all very much. Thanks to all of the presenters. Thanks to Timothy for making this first virtual Share Fair happen. I would say making this first virtual Share Fair a success. Over to you, Dr. Adams.
Yes, thank you very much, Shanti, and thanks to you as our knowledge coordinator who have been behind all of this, and to Timothy. Being mindful of the time, I'll only take 2 minutes. Thanks to the presenters for really excellent presentation today, sharing what you've been doing in terms of validation or on your road to validation and revalidation. Also, thanks to Sandra and to Valerie for also being supportive and also stepping in terms of giving their perspective on the process. To all of the participants, thank you very much for your participation today. As Shanti said, this is our first virtual share fair. We were a bit nervous in terms of how it will happen, but I think that as Shanti said, I will rate it as a success. I think that we had very good presentations, very good discussions. The expectation board did work, the polls did work as we wanted them to, and so thanks to all of you. I'll remind you to use your social media, use these hashtags. I'm sure that you will see Timothy sending out these hashtags to you, so you can just copy and paste. Timothy will send them in a mail or something so that you can copy and paste, and when you paste, when you post on social media, etc., please include the hashtag so that it will clump all of these together in terms of how social media works, and people can see the work that we're doing with respect to our share fairs, but also EMTCT. So again, thank you very much. Stay tuned. You will hear from us in terms of the next share fair, the topic that it is going to be on, and we also invite you to disseminate widely these notices when they're sent for you, because we share very important information that can be used widely across the region to strengthen health systems and to really strengthen the response to HIV, STI, hepatitis, syphilis, etc. So again, thank you very much. Do enjoy your weekend. Continue to be safe, and all the best. Take care. Over, Shanti.
Yeah, thank you, Rasman. Thanks again, everyone. Just to follow up on Dr. Rasman's point, the next share fair is on June 25th, and it's on pre-exposure prophylaxis. So stay tuned. The announcement will be going out shortly. Thanks again, everyone. Have a great weekend.